Welcome along to Diabetes Chat. Hope everyone is doing well on this Monday night. If you do want to get involved tonight, you can hashtag Diabetes Chat, join the panel by pressing the mic button, and Claire will bring you up to the panel. So if you do have any questions for Becky, please fire them over to us or join the panel and we will get that to her. So let's start tonight's chat. Tonight on Diabetes Chat, we welcome Dr. Rebecca Thomas as our guest speaker. Dr. Thomas is a Senior Research Officer and Informatics Lead at Diabetes Research Unit Cymru, based in Swansea University. She is also a Senior Lecturer, and in 2015, Dr. Thomas obtained her PhD from Cardiff University School of Medicine and has worked at Swansea University for 8 years. Tonight, we welcome Becky to Diabetes Chat. Becky has appeared on Diabetes Chat before when we did the research event early in the year, was it? I think. And you can go check out that previous Diabetes Chat, and there's lots of slides that Becky goes through. Tonight we've got audio chat, so hopefully everyone's comfy in their onesies on this cold, wintry night in December. So welcome, Becky. Welcome to Diabetes Chat.
Thank you. Thank you for inviting me on for this Diabetes Awareness Month as well. Amazing.
Absolutely. Yeah. Happy Diabetes Awareness Month to everyone. So what we'll do, we're going to do some quick 5 questions just to quickly get to know you. And then we're then going to delve into some background on your connection to diabetes and your role now. And then our main chat in about 15 minutes time is we will be talking about eye health, and we've got some questions. Thank you so much for sending some over, and we've got some questions, additional questions already sent through. And again, if you guys have any questions, please send it through or come speak on the microphone. So just some quick 5 questions. You don't live with type 1, do you, Becky? Just a double check.
I do not know.
No worries. So you might have heard of our quite famous 90-second questions. We try and get through the questions in 90 seconds. So first question, I'm going to kind of flip it because you don't have type 1 or diabetes. I'm going to flip it to see your reaction of if you were type 1 or had diabetes, some of the sort of treatments and things, how you feel, etc. So if you were living with diabetes, what would you say would be your go-to hypo treatment?
Oh, squishies. I love squishies.
Oh yes. Did you get loads for Halloween? We've got loads here.
Yes, the kids had loads. They've been great. I don't think there's any left. I think I've probably eaten them all.
Yes.
I would never be hypo. I would always be high.
I know we've got the big bag and big box of Haribo sweets. And I keep going to nick a bag or 2 every so often. Okay, next question. If you had a choice of insulin pens and pump, what would you prefer, do you reckon?
I am definitely a tech kind of girl, so I would probably say a pump.
What do you think's worse, feeling low, hypo, or hyper?
Well, I can say that I've experienced hyper before because on my second pregnancy, I had gestational diabetes. So I have experienced the hyper before, and that really wasn't very nice. Yeah. But I've never experienced a low. But I would imagine that could be quite a bit worse.
And during that, did you have like technology to manage your diabetes? Were they tracking your levels and kind of seeing how you go on? How did that experience go?
I was finger prick testing, and it was horrible.
Yes. And you know, for women who go through that now, do they go into CGMs or do they have finger pricks? We're not too sure.
Yes. So anybody with GDM or type 1 or type 2, they would have a CGM.
CGM, brilliant, thank you. Yeah. One thing you like about diabetes and one thing you don't like about diabetes?
Oh, one thing I like about diabetes, I would have to say the community. You know, the healthcare professionals that I meet, people living with diabetes. There is an amazing community of people supporting and helping around diabetes.
Yes.
And what I don't like is just, it's relentless, isn't it, guys? I mean, You guys don't get a day off. I can lie in bed when I'm not very well and just sleep and
Yeah,
just feel miserable. But you guys have still got to look after your diabetes. You've still got to do the testing. You've still got to take your insulin. I
definitely.
just think it's hideous.
It's that job that we never applied for, and it's just there for life, on addition to
Yes.
everything else. So it's not like, well, that's it. We have to still live on sort of normal life, right?
Yeah, and you never get to clock off. Like
Absolutely.
work, you get to clock off, but
Yeah, yeah.
not from
And, e-
diabetes.
and even with great advances, look, we're in a good era now where there are tech
Mm.
advances, and like you mentioned, CGMs, and you said about pumps and hyperclosed loop and stuff like that. And there's different preventions coming through in different studies like ELSA and stuff like that. But you know what I mean? It's not that cure. It's not that, you know what I mean? It's still, there's
No.
still a lot of work to it. It helps technology, and especially like hyperclosed loop does help, but
Yeah.
you can still go through all the roller coaster with it, isn't it?
Yeah, you still got a carb count. You still got to put in your bolus doses. Even with hybrid closed loop, you still got to do some work with it. So
Absolutely.
I know it takes away a lot of the background noise, but you're still thinking about it. You still got to, if you're traveling, I can the video from Breakthrough Type
Oh my
1D was
gosh.
really interesting. I loved that one
Yeah.
that they put out last week, I
Last week.
think it was,
Yeah.
wasn't it?
Last Monday. Yeah.
Um, and it was just the image of the guy as he's trying to leave the house,
Oh, at
and
the end,
I can just pick up my
John,
keys. You
John,
guys can't do that, you gotta think, have I got
yeah, yeah, yeah. It's, you walk out the door and you do them pats. It's not just a wallet tap and a
yeah.
key tap. It's like, have I got that? Have I got my spare pump or my spare CGM or my hypo treatments or the whole kit, isn't it?
Yes.
So yeah.
Yeah.
Last question for this section. Do you have any preference on the smell of insulin? Do you love it or hate it, or no sort of
John, don't think I don't think I can ever say that I've ever smelt insulin.
next time you're in clinic, you'll be observing it now, won't you?
Yes, yeah, yeah. Next time we run the diabetes course, I'll have to ask people what their insulin smells like.
We did
I
have a
don't have
chat.
a very strong sense of smell anyway, so
We did have a
maybe
chat
that's
once,
it.
and someone, I can't remember who it was, but one of the guest speakers, it might have been a consultant, and or someone said sometimes there's different smells to different insulins. And I'm like, wow, okay, that's
Oh.
taking that question to the next level, really. I didn't realize Fiasp or Lumjo or whatever, different insulins would smell different, but apparently they do. So I've learned something.
Mm,
Okay, brilliant stuff.
interesting.
Yeah. So if you do have a question, please hashtag diabetes chat. Come say hi to me and Becky. Let's start there, Becky. In the next 10 minutes, let's get to know you a little bit and your connection to diabetes, your career background. So to kickstart, like, why diabetes? Like, what for you fascinates you about diabetes? And do you know anyone who has diabetes, like a friend, family member, someone, before you went in to do your studying and stuff like that, and obviously progressed to get to where you are now? What fascinated you about it, and did you know anything about diabetes or know anyone?
No, so when I first started, I sort of fell into diabetes as a career. It wasn't a
Wasn't
conscious
planned.
choice. No, it wasn't planned. I finished my undergrad degree, and I was just working with a family member in a health authority doing some work. And at the time, they were just starting to set up the screening program in Wales for diabetic
Mm-hmm.
retinopathy,
Mm-hmm.
and I bumped into the program manager in the corridor, and we started talking, and she said, "Oh, I've heard some things about you. You should come and interview for a job with me."
Wow.
um, and that was how I fell into diabetes. So I started life work in diabetes as a retinal screener grader.
Okay. So
So I would
is that when you go to get your eye screening?
Yes, yes. You go, you get your photographs taken, and then the photographs get sent to a grading center. And I was sat in the grading center, and it wasn't a great job because You, especially in the winter, you go to work in the dark, you work all day in the dark, and then you leave and it's dark.
Oh my goodness.
Yes, because we're not allowed, you weren't allowed any glare on your screens. So all of our windows were double blinded. So it was completely pitch black. It was, it's amazing.
Fun times indeed. And then how did your career then progress then to where you are now? So what is your role now, and kind of how did you get from that then, from screening in this sort of dark labs to where you are now?
So I think I was lucky. I was right place, right time.
Yeah.
So I got into the screening service right at the start when they were starting to set up. And then because I was we were trying to get more senior level management staff. So because I was first in, I was one of the most experienced. So then I became a senior grader. So I was training everybody else to grade. And because of that, I was sat with my clinical director, the amazing Professor David Owens, who's been my mentor now for at least 15 years. He said, I'd sit there with him and we'd argue over what the grade of retinopathy was, what I thought was an X date, what I didn't. And he'd sit there and he'd be testing me constantly. And it was great. It was, he's a great guy. And then he said, right, you need to come and do your PhD with me. I was like, oh, okay, that could be a good next step for me. So I left screening and went to Cardiff Uni to start my PhD. So I looked at screening intervals, which might be something we talk about later on, maybe.
Yeah.
My PhD was looking at how frequently we should screen people for diabetic retinopathy. Are there people we could screen more frequently, less frequently? Does everybody need to come in every year? So that was my PhD. And then I finished that and went to work for public health for a little bit. And I did a couple of systematic reviews with them, and then eventually joined Swansea. My diabetes team in Cardiff moved down to Swansea Uni, and eventually they got me a job down there. So I worked for the Diabetes Research Unit Cymru for about 5 years, did a couple of postdocs, did a couple of research projects with them. And then 2 years ago, I became a senior lecturer in Swansea. So now I work on a couple of courses. So I work on the undergrad, so BSc degree, Population Health and Medical Sciences. And then I'm also program director for our MSc in diabetes practice that I run with Dr. Sarah Pryor. And that's for specialist nurses or any healthcare professional within the diabetes field. So we have a lot of dietitians and pharmacists. So it's a master's program for those to get more knowledge.
Yeah, is that 1 year course?
Experience. It's 2 years. 2 years part time.
Yeah. Brilliant. So you kind of get answered my next question. Really, is sort of what does your day-to-day job look like now then? But I guess it's them sort of juggling roles between as a senior lecturer and everything else. Really, is there anything else you want to add on to that? Or
I mean, a lot of my time is spent dealing with students. So we do a lot of sort of pastoral care with students, making sure they're all right, because obviously they're away from home for the first time. So a lot of my time is taken up with that, but I do a lot of research projects. I spend a lot of time writing grants. And I do a lot of statistical work as well. So in Wales, we've got a big data bank called SAIL. And that's got all of our primary care, all of our hospital records, we've got education records. A lot of data goes into this, and we link it all up across, and we can do a lot of epidemiological research. So I do a lot of that sort of stuff for diabetes or set up diabetes projects in there. So it's a really varied role. I do a lot of committee meetings, a lot of education.
So what would you say? What would you say you love? What would you say you love the most about the job, or what challenges do you face? Would you say?
So up until 2 years ago, I was purely research grant funded.
Yeah.
And so the biggest challenge was making sure I had a grant to cover my salary.
Wow.
Um, and at one point, I was on 3-month contracts,
Yeah.
and your contract might be renewed, maybe 12 hours before your last one finished, and it's that real uncertainty that comes with research contracts.
Yeah.
Um, so that was a big challenge. Now I'm a lecturer, so the university actually pays for me, so I
Yeah.
don't need grants so much to keep myself going, but obviously
No.
to fund other people to do some work
Sure.
around diabetes. We need
Yeah.
plenty of grants to come in, but getting grant funding is the biggest
Pretty challenging.
challenge.
Mm-hmm.
Yeah,
Mm-hmm. And what's the reason behind that?
there's just no. I mean, there are so many conditions, diseases, illnesses that need more research, that need more,
Mm-hmm.
treatments and everything else. We're all fighting for the same pots of
Pot of
money.
money. Yeah.
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 And whether that's, Diabetes UK fund grants, or whether that's funders like NIHR or MRC, or then the big European funders,
Yeah.
like all different conditions are going for those same pots of money. So
Absolutely.
you have to make sure your ideas are top notch, and it takes you so long to write a grant, and then for them to come back and say no, it's like, oh,
I know. I know.
I've got to rewrite it again and put it in somewhere else. So
Yeah.
it's hard
Yeah.
work.
Especially like if we look at say diabetes, just as one our condition is within diabetes. There's so many avenues that you can go down to look at research in it. So within what I mean,
Yes.
especially within your field of diabetic retinopathy, like looking at technology and especially now with hybrid closed loop. I remember your
Yeah.
talk at the event a couple of months ago, and then you got things like pregnancy, menopause. You know what I mean? There's
Yeah.
so many avenues that are so important to everyone. But like you say, it's trying to compete to get the money for the grants
Yeah.
and do the research and carry the research out. And you know what I mean? It's quite overwhelming, really, isn't it?
It is. It's really. I think when I first started out, somebody told me you would apply for 30 grants to get one funded. So it's
Mm,
quite a lot, a lot of work. And yeah, as you said, like even when you're going for a funder like Diabetes UK, who only fund, or JDRF,
yeah,
who only fund diabetes work,
yeah,
like you are competing with all of the other conditions, all the other therapies,
yeah,
there's so much that they could fund. They just want to make sure that their money is used the best that it can be,
yeah,
but it just makes it very difficult to get.
definitely. So before we go on to sort of the main chat tonight to talk about eye health, is there any particular studies or research that you've been part of that you could share, or like whether you've been part of, whether you've kind of run that study or research or part of the team? Is there any within that you'd like to share or just acknowledge? I guess you've had so many, I guess, over the years, but like, is there anything that stand out for you?
Yeah, I mean, we've just had, I'm just finishing up a couple now. So we've got one that is looking at COVID, the impact of COVID
Hmm.
on diabetic retinopathy screening programs, and how they've recovered, and what
Hmm.
lessons we can learn should we ever get another pandemic. So I'm just writing up the report for that now. A
Yep.
lot of interesting stuff comes out of that. But a lot. So we did some qualitative work. So we did a lot of interviewing,
Yeah.
and as I get all the time from Twitter anyway, there's a lot of harm being done by the results letters from screening.
Hmm.
Um, and I think that is something that we're really going to have to sort of address in the future. That there's got to be a better way to deliver these messages.
Yeah,
Um,
definitely more inclusive to language matters and getting the right approach, done in
yes,
the right way.
yeah, and I
Absolutely.
Yeah, and another one we're just finishing up now is called Cymr, and that is looking at how do we do how do we screen better for all diabetes complications, but amongst minority ethnic groups. How do we get them into screening? How do we get the messages across to them? And that's been a really, really interesting project, and one that we've learned an awful lot about. And the main messages out of that is the third sector organizations are your best friends.
Yeah.
They know these populations, they know what's going to get them in, and how to best invite them, and they are your best friends.
Well, that concludes that first section of tonight. I hope you guys find it really helpful to kind of get to know Dr. Rebecca Thomas a little bit more. Let's just see if any comments come through so far. I can't see any. So we're going to move on to our next section, our main chat of tonight. We're going to talk about eye health, something which is obviously part of your background, close to your heart. You're very knowledgeable in this area. And we've got some questions that we want to pose to you. If anyone else has any other questions, please let me and Claire know, and you can hashtag diabetes chat, or you can come join the mic. If you're listening back on demand, then you will be in for a treat, I am sure. So let's kick off. Basically, what is diabetes, diabetic retinopathy? Like, from what I see, are there 4 stages? Are you able to explain them for us, like what differences are? For us tonight?
Yeah, so there's diabetic retinopathy and there's diabetic maculopathy.
Okay.
And they're similar but different. So diabetic retinopathy happens because of high blood glucose going through all of your organs within your body. It makes your blood a bit sticky, and the blood vessels through your eyes, being the smallest blood vessels in your body, your eyes, the ones in the eyes generally tend to get damaged first. And it basically means that the blood vessels, they will either close off, and that's when we get the first signs of diabetic retinopathy. So that you get microaneurysms, which, if you can think about when you used to do finger prick testing, and you would prick your finger, that tiny spot of blood on your finger, that's basically, that's a microaneurysm in your eye. It's really small. And that's the first stage, that's the first thing we see. It's the first stage of diabetic retinopathy.
And when you say because of high levels, is that over a period of time, like a duration of living with diabetes for a period of time, or like because of extended period, like prolonged high levels, like, or is it obviously very independent on circumstantial?
No, it's over a long period of time. So it's more like at least 10 years.
Okay.
That kind of it's at least 10 years before you're going to see sort of retinopathy starting to develop. And there are some figures that would say that after 20 years of living with type 1 diabetes, about 90% will have diabetic retinopathy. So it's, and I don't like giving out that stat all the time, because that makes it seem like it's inevitable. But what I mean by that 90% will have retinopathy is that you're not on your own. So that's the first thing I want to point out is, just people who develop diabetic retinopathy, you're not alone. There are a lot of people who will develop diabetic retinopathy.
Can you reverse it then?
Oh, so this one is out for debate. It's, some people say yes, some people say no, but because it's not a permanent condition. So if you think about a hemorrhage, so if you think about, you've hit your leg, you've got a big bruise on your leg, that's going to go and fade over time. Well, retinopathy is similar in that the blood vessels will close off, and then that blood will get reabsorbed by the eye. And then but that doesn't mean that the retinopathy's gone away. That little bit has gone away, but then you're going to get more. And there's a famous ophthalmologist who's called Eva Kona, and she found that if we can see one microaneurysm on the retina in a photograph, if we did a fluorescein angiogram, which is another which is an older way that we used to detect diabetic retinopathy, you would see 10 microaneurysms. So it's a transient condition that comes and goes for a long time, and it just, so when we take a retinal photograph, it's just a moment in time, and it could just be that at that time we can't see it on the retina, but it doesn't mean to say that it's gone. So whether or not we can reverse it or not, I don't know. We can. You have seen people, so all the stages are not set in stone. You can go. I've seen a lot of people go from background retinopathy to nothing, back to background retinopathy, back to nothing. So there's a lot of to in and fro in, and that happens with pre-proliferative as well. So the next stage is up. So there is a lot of back and forth, but whether it's actually reversed, I don't know.
Yeah, I guess that where it goes back to that bigger question before about research. So the more research in these fields, and more data, and more analytic data and stuff like that over a period of time, is we can then get more information about all this sort of stuff, right?
Yes, yeah, definitely.
So you said there's four stages. Then do you progress?
Yes.
Do you progress up with linear? You kind of go 1, 2, 3, 4, or can you go from stage 1 to stage 3, 4? Like, can you do that, or is it in a process? And could you just go through a little of each, if that's all right?
Yes, yeah, that's fine. So if I go through each of the stages first, and then I'll come back to whether or not you can go jump them. So background retinopathy, that would be your tiny microaneurysms. It would be so your microaneurysms come when your blood vessels close off. The other bit is when the blood vessels leak out. So the blood leaks out of the blood vessels, and you get hemorrhaging, and you get what's known as exudates, we call them. It's like lipid fatty deposits, and they look yellow in the eyes. So that's fluid leaking out of the blood vessels. All of that can happen in background retinopathy. For screening purposes, you would have to have 8 or less than 8 hemorrhages for you to stay within the background retinopathy category. So we've got some arbitrary cutoff points for that. So you can have anything from 1 single microaneurysm to 8 hemorrhages and lots of exudates, and you would still be in that background retinopathy category.
And is it over 2 eyes, or 8, like 4 in one, 4 in the other? Does it matter, or?
So that would be in one eye.
In one
eye. So we would give grades. Yeah, we give grades based on each eye, each individual eye.
Makes sense. Silly question from me.
Could have. It's never a silly question. So you could have retinopathy in one eye, and you can have nothing in the other eye. So you can. Usually we tend to see both eyes progress at the same rate, but you can have one progressing faster than the other. Once you get more than 8 hemorrhages, and you get what we call in screening cotton wool spots. So these are areas of the eye that look very pale and very much like a ball of cotton wool. But these are areas that are, because the blood is leaking out of the vessels, it means that patches of the retina are not getting oxygen, and so they look like these cotton wool spots, and they're just areas that are deprived of oxygen. And then you get changes happening in your vessels themselves, so they'll change shape and size, and so we get something that's known as venous beading. So that's all in your pre-proliferative stage. So background retinopathy and pre-proliferative, you would have no visual symptoms of. So you wouldn't know without screening. You wouldn't know that you're in those 2 categories. They don't need treatment. Neither of them need treatment either. So we just need to be aware that we've got these, so that we can try and make improvements in diabetes management, so that we can stop it progressing to the next stage. So from pre-proliferative retinopathy, you would go into proliferative retinopathy. So that is when those little areas of cotton wool spots that I tried and probably failed to describe very well.
No, you did great.
those areas that are not being supplied with oxygen, what the eye does is try to resupply those areas with oxygen. So they so it grows its own new vessels, trying to resupply that oxygen that it's missing. But those vessels are really weak and fragile, and they'll break really easily. And once they break, they bleed quite a lot. And when they bleed, that's when you notice. That's when the visual symptoms start appearing for you.
Right.
The problem with that is that, and so while it's all bleeding, we can't see the new vessels underneath, and we need to laser those new vessels, but we can't do it unless we can see them. So we have to wait for the eye to reabsorb all of the blood, which then means that the eye's got more time to keep growing new vessels, and so you will probably need more laser than if we picked up the new vessels before you got visual symptoms, and before they started bleeding. So that's why we screen. We want to try and pick it up before you notice anything.
Yes.
So those are your retinopathy stages. You also get a maculopathy stage. So this is in screening. Screening generally tends to use maculopathy, whereas ophthalmology would use diabetic macular edema. But because in screening we rely on 2D images, we can't see where there's fluid leaking out and where there's swelling in the eye. And it's the swelling that is the macular edema. And so we use maculopathy because we use surrogate markers, markers that would generally make us more suspicious that there's fluid leaking out and edema is forming. And this happens within a specific area of the retina. So it happens within the macular region, which, so I'm trying to describe the anatomy of the eye now without any images, so this is tricky. But the macular area is responsible for all of your fine vision details. So your ability to read, your ability to recognize people's faces, that all comes from this macular fovea area. And so any swelling within that area is going to be quite sight threatening quite immediately, because the rest of the eye does all of your surrounding vision, makes up the rest of the picture. But that macular area is really, really important for your central vision. And so if we see any of the exudates, so that fatty deposit, if we see that come in within this macular zone, we would call that diabetic maculopathy, and we would refer you in to ophthalmology for further tests and to see if there's any swelling related to that. Now, if those exudates occurred outside of that macular zone, you would still be in the background retinopathy category. But if they occur within the macular zone, you've now got diabetic maculopathy.
Okay.
And that's where the scary part comes, because all of a sudden you've got this referral into ophthalmology, and everybody gets quite scared at those letters, as I would as well. But all it means is we've seen something. We need to get you more testing than what we can do in screening. And it could be that there's nothing wrong and you end up back in screening anyway. So maculopathy can occur at any point. So it can come with background retinopathy, it can come with preproliferative retinopathy, and it can come with proliferative retinopathy. So it can come at any point. And then if I go back to your point about can you skip and jump categories. So generally, retinopathy will develop, it's progressive, so it will develop through stages. Now, whether in screening we pick you up when you've got background retinopathy or we pick you up when you've got preproliferative retinopathy, it just depends on when you come in to see us. But if you've got preproliferative retinopathy, when you come into screening, at some point you would have had background retinopathy. It's just that we haven't seen you, we haven't picked it up. So
absolutely. Oh, that's really interesting. And kind of like when I've seen your talks and we did a previous diary chat when we did see visuals, but kind of just listening to you and kind of creating my own images in my own head, it's quite a different way to kind of take that sort of knowledge in. So honestly, thank you for that. So can I ask then, the question we got, so I've got diabetes, so is diabetic retinopathy and blindness inevitable? What's your thoughts there?
Oh, so blindness due to diabetes is not inevitable.
Yeah.
Blindness due to diabetes is very, very preventable. So that's the one thing I want to say.
Brilliant.
So if we go back to my 90% of people with type 1 will develop retinopathy after 20 years.
Yeah.
That kind of makes it seem like it's inevitable. But most of that is background retinopathy. So it's not going to affect your vision. It's not going to affect your sight.
Yeah.
It's background retinopathy, and it's just what I would like to use it as. It's an early warning sign. Something's not quite right. Something hasn't been going well for a while. And now we need to really jump on, diabetes management, blood pressure management, and all of that, and just make sure everything is as best as we can get it.
Yes.
So that we can stop the retinopathy getting worse, and we can maybe prevent some of the other complications that we can't see or detect as early or as quickly as we can retinopathy.
Yeah, that's great. So a follow-up question on that really is, can people who are at risk of diabetes retinopathy, can they, because of sudden drops in A1C, HbA1c, can that cause DR?
Oh, this one's a hot topic at the minute. So if you do not have diabetic retinopathy, you do not have to worry.
Yeah.
So all the studies that I have seen, if you don't have any diabetic retinopathy to start with, a drop in your HbA1c isn't going to make you develop diabetic retinopathy.
Okay.
If you have got diabetic retinopathy and your HbA1c is high, and by high, most people would say that is above 10% in old money. I don't know what that is in millimoles per mole, but if it's above 10%, then dropping it quickly, you could be at risk of making your retinopathy get worse.
Okay.
So
what's the best advice on that? What can the person with diabetes do, or what can the diabetes teams do to help in that case? I'm trying to put it to a scenario. So if someone got hybrid closed loop, do they have support in that to kind of ensure that they don't go from, like you say, potentially above 10% to I don't know, 6.5% rapidly, quite quickly? Like what support's out there for that?
So this is an area that is really lacking in research.
Okay.
So that's my first plug. If there are any funders listening, we really need the research in this area. So what we think happens is that if you drop your HbA1c by 2%, 1.5% to 2% within 3 to 6 months, you are the ones who are going to be at risk of your retinopathy getting worse.
Yeah.
If your retinopathy is in that pre-proliferative category, or proliferative, or you've got diabetic maculopathy, then you're at risk of probably needing some treatment to try and help you, and of needing more. So that's what's the risk is. For hybrid closed loops. Partha, who I know you've got coming on in a couple of weeks, I think it is.
Next week we can ask him.
There you go. I worked with him to put a pathway together for teams to try and help reduce the risk, or to at least raise awareness of the risk. So What the pathway says is, if you're considering hybrid closed loop, get retinal screening done. That's the first thing, so that the teams know what the levels are and what the risk is. So make sure you have your retinal screening done.
Within a period of time. So if you were seen, I don't know, 6 months ago, would you need to do it like again, like now, or is it like 6 months okay? Like, do you know what I mean? Do they need straight away, or?
Yeah.
Okay.
No, if it's within the last year, and it should be okay.
Okay.
Last 12 months.
Yes.
So if you obviously screening intervals have changed, so it's a bit of a grey area, but within the last 12 months, they should be
okay with that. Yeah.
Okay to go off that as a baseline. If there was no retinopathy or background retinopathy, then you're okay to start the hybrid closed loop. If it is pre-proliferative retinopathy, or diabetic maculopathy, what we've come up with is those people should be under an ophthalmologist anyway. And so the diabetes team should be having a discussion with the ophthalmology teams to say, to try and work out, is it safe for us to start this right now?
Yeah.
So, and a lot of people come to me and have said, well, will the ophthalmology teams know what hybrid closed loop is? No, it's the same for GLP-1 as well, for a lot of other things. So no, the ophthalmology teams probably won't know, or may not know, where a hybrid closed loop is. They may not know where a GLP-1 is. They may not have that knowledge of those trials. They've got their own trials of treatments going on. So, it's difficult enough keeping up with your own area. But what they will know about is the rapid reduction in HbA1c and the risk of early worsening. So they will be aware of that. So what you need to be what your diabetes teams need to be discussing with the ophthalmology teams is, we're going to start this new treatment, this new therapy, the hybrid closed loop, in this person. We are aware they have pre-proliferative retinopathy, or they have proliferative retinopathy. Are they under your team? Have you seen them? That's the first question. If they've seen the patient, then you can then have a discussion on, should we start it now? If they haven't seen the patient, I would suggest waiting until they've been seen in ophthalmology, just so that you know where they are in the system, and they are being seen. If they've been seen and it's been confirmed, their diagnosis, because screening isn't diagnostic, so we only we send people into ophthalmology for that diagnosis, and we're sending people who we've seen who's high risk. So we need that diagnosis first. So once the ophthalmology teams have seen the patient, if they are monitoring, and they can monitor every 3 months, then they are likely to pick up any worsening of retinopathy because of the hybrid closed loop. And so they can start treatment straight away. If they are going to start treatment, it may well be worth waiting until after they've had the treatment for their proliferative retinopathy or their diabetic macular edema before we start the treatment. So for proliferative retinopathy, it's a little bit easier because you need laser treatment. It's usually covered off within 2 to 3 laser sessions, which are done within 2 weeks of each other. So, you're talking about 6 to 9 weeks wait in total for the laser treatment to be done, maybe a bit of a period afterwards to let the eye settle down and everything calm back down, and then start the hybrid closed loop with ophthalmology doing those 3-month follow-up checks. If they're going to start, if it's diabetic macular edema and they need to start anti-VEGF injections, it's a little bit more complicated because, those injections could go on for 2 years, they could go on for 5 years. So we're trying to discuss when the hybrid closed loop should happen, but they should probably have at least their loading doses of anti-VEGF and then start the hybrid closed loop. So, there are some conversations, but then the one thing that really needs to happen is that the diabetes teams need to have this conversation with the person living with diabetes. They need to know their risk. They need to know that this is a possibility.
Yeah.
They need to know that it is vitally important that they are going through screening, that they are going for their ophthalmology checks, and they also need to know what the signs and symptoms are of an emergency eye situation.
Yes.
And where to go to seek help if they find themselves in that situation, because trying to get a GP appointment and then turning up and your GP saying, well, there's nothing I can do for you because I can't see your eye, isn't very helpful, and it just wastes time. So, knowing that your best place to go is your optician.
Yeah. Yeah.
Or if you can't go there, then a lot of places will have hospital eye casualties, and turning up at one of those is probably better than waiting around
Waiting until the
for
next
a
screen.
GP appointment.
Yeah.
Yeah.
Wow, thank you so much.
Yeah, so we can't. So the problem we've got is with hybrid closed loop, we can't, and a lot of these other therapies, we can't slow down the drop in HbA1c.
No.
So, what I would say is, if we could have a running period of, 6 months maybe, or a year, where we're dropping the HbA1c slowly,
gradually, yeah,
before we start hybrid closed loop, that's probably better. But people have had diabetes for a long time at the moment before they're getting the hybrid closed loop, and they're struggling. And so, you don't I don't want, what we don't want is to have people with retinopathy being denied these life-changing therapies and treatments,
yes,
because of the risks to their eyes. But they need to be aware that there is a risk, and they're the ones taking that risk.
Like you said, it needs to be all explained, doesn't it? Working all in collaboration together with the patient and being well informed. No, that's great.
Yeah.
So let's have a look at some of the other questions coming through. So let's go to the screening letters then. So the screening letters can or are pretty scary at times. And you mentioned before about the sort of research you were talking about. What's your thoughts on sort of screening letters, and what needs to be done, do you think, and will it be done? Will that sort of area be improved in due course?
It's something I've been working on for a long time, and it hasn't happened yet. So screening is a difficult place, because they have to do it for the biggest majority of the population, and a lot of people don't want a lot of detail. So they want to know, are my eyes okay or are they not? And that's about all. So a lot of people will want that. And then other people will want to know the ins and outs of everything, and what they can do to stop it getting worse, or is there anything they can do to make it get better? And so it's very difficult in a one-page results letter to hit the enough detail for everybody. But what they've gone and done is not given any detail whatsoever. And they did, I know the Welsh screening program a couple of years ago worked with a few people with diabetes to try and change their letters. They did change them a bit, and it's not worked. They definitely missed the mark. And I just think it's a missed opportunity, because you get a results letter through your door, and it tells you you've got background retinopathy. Now, if that lands on your doorstep on a Friday night, you've got absolutely no support, and there's nothing in the letter to point you in a direction to go and find out more information either.
Absolutely.
Because there's a lot of information online, but not all of it is true, and not all of it is factual. So, those letters can do a lot more good than what they actually do at the minute. And I think getting our diabetes teams involved. I think there's some work that our diabetes psychologists, I can see Jack is on the call. I think working with our psychology teams, I think we can get those letters into a much better state that they can at least give us some information and point us to more information if you want
Definitely.
to go and look
So
things
so
up.
so where's the screening letters coming from? Who's doing them? Is that like part of a board? Like who does
Yes,
that?
so in Wales, they come from our screening program, which is run by Public Health Wales.
Yeah.
And obviously they've got all of their other cancer and all the other screening programs. So they
Right.
want a similar sort of
Tone.
letter going out from, yes, from all their programs. For England, it'll come from, you've got your National Diabetes Committee, and they generally set the letters, but then each individual program can make alterations to them.
Yeah.
So you've got something like 64, I believe, screening programs in England. So it could be a slightly different tone
Yeah.
from each of them. So it's a big job in
Yeah.
England to get them all changed.
I think, like you said, I think they need to speak to people like yourself who are in the field,
Yeah.
like psychologists, like you've highlighted Jack and other fantastic psychologists, other healthcare professionals, and also us as people living with diabetes.
Yes.
Like we
Yes.
should be we should be the most important thing here, the center of it
Of
all.
course.
But yeah, so hopefully things will improve. Like I said, it's getting the message across. It has to get the correct message across, but it has to be in the right manner and be supportive as well, rather than saying you've got DR and then it's kind of like, but what now? Like, what can I do?
Yes.
How's it treated? What is it? How do I prevent it? How, you know what I mean? Like, what do I need to do, rather than Googling on a Friday night, like you said?
Yeah. Especially those the referral letters. So when you get the letters to say, I think at the minute it says, we have seen some changes that require further assessment, so we have referred you. Now, that is a really scary letter. But what it's not telling you is where they've referred you to, how long it's going to take for that appointment to come through. You know, there's nothing to follow up, and there is, you know,
it's just a standard line, isn't it? They've generated off a computer system, but what does that do to people? It puts them in the position that they feel scared, like hopeless. You know what I mean?
Yeah.
Defeated. They blame themselves, but
it's a
not
lot.
necessarily all that. You know.
Always. Yeah, it's a lot of unnecessary, you know, stress and anxiety that they cause that we really need to, you know, get rid of. But also, with that referral letter, one of the things that I say to patients is that ophthalmology is a difficult place at the moment. And so it's quite easy for appointments to fall through and for you not to be notified for an appointment. So if the screening letter isn't telling you where you've been referred to or who you've been referred to, you've got absolutely no way to follow that up and chase it up and to find out where you are on the waiting list. So you're just sat there
waiting,
and you've got nothing. You've got absolutely nothing. So I just don't like them. They're horrible and they need to change.
We like that. Right, some quick 5 questions. We're going to come back to screening and how it's changed shortly, but sort of quick 5 questions because I'm looking at the time. I don't like the dilated eye drops. Do I have to have them, Becky?
Oh, dilated eye drops. I know they're horrible, but for somebody who used to be a grader, they make a massive difference to the quality of the image that we get to see.
Okay.
And it makes a massive difference to us being able to pick up those really small changes that I talked about.
Right.
So there is some things that they are looking at in screening as to whether or not you can do it as a stage process, whether, you know, if you're under the age of 30, your eyes tend to dilate a lot easier than if you're over the age of 30. And so maybe if you're younger, you might be able to go without the drops. They are looking at more of a stage process, but then that might make your appointments longer if you have to then have your drops put in. So there are some things they're looking at. There are some new cameras that have just come in as well that they're going to trial out without dilation and just to see. So there are some things coming, but at the moment, it
that's the
makes a
best
huge
possible
difference
thing.
to the grader.
Yes.
Yeah.
Next question. I have my eyes screened at my optician's. Do I need to attend a diabetic eye screening appointment as well?
Yes. Unless your optician is part of the NHS diabetic eye screening program within your area, you need to attend your eye screening appointments as
Yeah.
well. The opticians will look for lots of other eye health changes
Yeah.
and also do obviously your vision check.
Yeah.
But screening is different, and so we need you to come to screening as well.
Brilliant. Cataracts and glaucoma, is it glaucoma? Other eye
Yes.
problems. Are people who live with diabetes at higher risk of developing cataracts and I can't even speak. All these
Glaucoma.
terminologies at this time of night. You know what? You know what I was asking you.
Yes, yes. Yes, people with diabetes are at a higher risk of both cataracts and glaucoma, as
Yeah.
well as having retinal vein occlusions and other things as well. So, yes, because of the change in glucose levels affecting the lens in front of your eye, it gives you a higher risk of developing cataracts and glaucoma. And they are two of the eye conditions that your opticians will check your eyes for.
Brilliant. Thank you. Pregnancy. You mentioned that before. So people who are going through pregnancy, women, can it worsen? Can their eyes worsen during pregnancy, or is there anything that they can do to help during pregnancy? Or yeah, so can it worsen during pregnancy?
Yeah. Yes, so they're in a similar situation as if you were going on a hybrid closed loop, if you're
Yes.
going on, a GLP-1. When you're going through pregnancy, your glucose targets are a lot tighter, and so you can drop your HbA1c very quickly. And when it becomes about the health of the child that you're carrying, mums are very good at protecting our babies. And so we can drop HbA1c very, very quickly during pregnancy. Now, the problem with pregnancy is that it's such a short period of time that we can't actually make that slower, because the outcomes for mum and baby are better with, that getting that HbA1c down quickly. So
Yeah.
for me, this brings in preconception care
Yeah.
and the importance of really, really good preconception care, because you can do that gradual HbA1c reduction in the preconception care state before you go into pregnancy, and then that will reduce your risk of your retinopathy worsening.
Thank you so much. So much coverage here tonight, guys. Really appreciate it. James Ridgway just tweeted, said, have been listening to tonight's diabetes chat. Very insightful information from Becky. Worth a listen for both HCPs and people living with diabetes. Thank you, James. If you have any comments, please put them in the chat. Simple question, straight to the point. How do I get an appointment?
An appointment with eye screening?
Yes.
You should be referred when you're diagnosed with diabetes, whether it's type 1 or type 2 diabetes. Your GP should be referring you, or your diabetes team should refer you into eye screening, and you should be called for an appointment within 3 months if you're over the age of 12.
Okay.
If you're under the age of 12, then you're too young for eye screening, and we don't screen you.
Is that on evidence-based stuff, I assume?
Yes, because it takes at least 10 years to develop diabetic retinopathy. And we see that basically, if you're under the age of 18, your chances of having even background retinopathy are so slim that it's not worth. And also, you have to be able to sit at a certain height of the camera as well. So that, that can be an issue. So under the age of 12, we don't screen you.
Yep.
If you haven't had an appointment and you're due an appointment, give your screening program a ring. They will give you an appointment if you are due. If they've missed you, they will apologize profusely and they will get you in. Some screening programs have online booking systems, so you can get yourself in, but don't be afraid to pick up the phone and give them a ring and give them a nudge if you haven't been screened.
Absolutely. Thank you so much. Which takes us then to next question. So screening, I've heard screening has changed. Is that true? And also just a side question really is when you go through the screening process now, how it's changed. Could you explain in relation to the 4 stages that we mentioned before? Do appointment screening change, like vary depending on the sort of grade, stage 1, 2, 3, 4? So if you had stage 3, would you be seen more frequent?
Yes. So basically, when we started screening back in 2003, we had no evidence on which to base how often we should screen you.
Yeah.
So we just fell in line with all the other 9K processes that you needed to have when you had diabetes. So we just went, let's just do it annually. Let's get everybody in on an annual basis, and that'll be great and fine. And we'll look at it as we go along. So, it's been 20 years now since we've had screening in the UK.
Mm-hmm.
It's a long, long time. So when we looked at it, we discovered that if you do not have retinopathy, your risk of developing diabetic retinopathy within the next 2 years is less. Not. I'll start there again. If you don't have any retinopathy, your risk of developing a referable level of retinopathy within the next 2 years is less than 0.5%.
When you say referable, do you mean going back to earlier on when you said there would be 8 things? I can't remember the terminology now, but 8 different things in the eyes. Is that right?
Yes.
Right.
So your hemorrhages.
I am learning. I am listening, Becky.
You are very much. So referable level of retinopathy is your pre-proliferative, your proliferative, and your diabetic maculopathy.
Brilliant.
Those are the 3 things that we would refer you into ophthalmology for. So
yes,
your risk of developing that level of retinopathy within the next 2 years is less than 0.5%.
If you've got no background
if you've
at
got
all.
if you've got nothing whatsoever in your eyes, it's a very, very low risk.
Right.
And so what they've done is they've reduced that risk further by saying that not only do you have to have no retinopathy in either eye at 1 screening, you have to have it at 2 screenings. So what happens is you come in for screening.
Yep.
If it's your first one and you've got no retinopathy, you'll come back for screening in 12 months.
Okay.
So you've got that second screening event in 12 months. If you've still got no retinopathy, then your screening interval will change.
Into 2-year periods.
Then you will go to a 24-month screening. And that's because your risk is so low. We don't want to put you through all this unnecessary anxiety, giving you all of these extra appointments. But it also means that once you've got pre-proliferative retinopathy, if we don't think that the ophthalmologists are going to need to treat you, we can see you in screening more often, which means that you don't need to go to the hospital. We can keep you within your screening service appointments. So what it's done is given us a bit of flexibility in the system to say, we don't need to see this group of people so often, so we can see this group of people more often. And if you've got background retinopathy, we will see you every year. So you'll still come in to see people every year. So that's kind of what it's done. Maculopathy falls in with background retinopathy, or it would fall in with we'd referring you to the hospital eye service. Or in some screening programs now, they're bringing in OCT cameras into the screening service, and so they'll follow you up every 3 to 6 months within the program. So there are going to be lots of changes, and this isn't the perfect system at the minute. So there is a lot more going on to sort of personalize this a little bit more. So maybe in the future, if you've got type 1 diabetes, you've had it for more than 10 to 20 years, and your HbA1c is above 10%, even if you haven't got diabetic retinopathy, you may then come back in on a 12-month basis because your risk is slightly higher.
Because like you said before, isn't it, 90% of TRs is in 20 years. So yeah, that's where that criteria. Yeah,
Yes.
makes sense. Makes sense.
Yes. So in the future, we are probably going to look at more changes coming in. But at the moment, that's the way it works. So if you've got no retinopathy, both eyes, at 2 screening events, you will be brought back in at 24 months. So you come in every 2 years
Yes.
instead of every year. That's the only group it's changed for, and that is because of this. They are at such low risk. There is
Yes.
some safety built into that. So if we've called you in for a screening at 2 years, and for whatever reason you haven't been able to attend, you will then be put back onto an annual screening cycle. So you wouldn't have to wait another 24 months to come in.
Yeah.
So, there's a bit of safety there. And also, if your diabetes team is concerned, if there's been changes, if your HbA1c is increased, or if they're about to start one of these new treatments, technologies,
Then you get it.
and they're a little bit concerned, they can phone up screening or write in or email them and ask for an earlier appointment for you as well. So there's a bit of safety in that.
Brilliant. No, that's really great. Hopefully that explains for people who are asking that question. Thank you so much. So just with stage 2, stage 3, stage 4, how often do they get seen?
So no retinopathy is stage 0. Stage 1 is your background retinopathy, so they would be seen every year.
Yeah.
Stage 2 is pre-proliferative. So that depends on where you're at in that pre-proliferative. You're likely to be seen every 3 to 6 months in screening, probably 6 months, I think. Or you'll be referred into ophthalmology and they will follow you up every 3 months. If you've got proliferative retinopathy, which is stage 3, you are under ophthalmology and you're having treatment anyway, so they will do your screening frequencies there. If you've got maculopathy, that is also dependent now on your screening program area, what they've got in Wales. They are all referred into ophthalmology. And some areas we will now use an optometry practice to do that ophthalmology follow-up for us. In England, you've got some screening programs that can do the OCT screening. So it's essentially another photograph with another camera that looks very similar, but takes a different 3D picture. And that will be every 3 to 6 months. So yeah.
So final sort of few questions. With screening, is that across the whole board of all four nations in the UK, all singing from the same hymn sheet, following that process, or do each area slightly change, or is that universal? And then second, is this out of interest, curiosity, is the screening processes systems for like globally around other countries? Do they have it part of the sort of toolkit, like the 9 cares that you said? If you could just share a little bit on that, if that's all right.
Yeah. So each of the 4 nations have their own sort of screening board that make the decisions, but we have the UK National Screening Committee that generally tend to, make most of the decisions. So UK National Screening Committee is a bit like NICE for screening. So they're the ones who made the decision on changing the screening intervals, and they're the ones who approved it. So it had to be evidence-based. The 4 nations have taken it up at different speeds. So Scotland took it up straight after COVID, so in 2021. Wales took it up in 2023, and England have started slowly rolling it out end of 23 into 24 and going into 25. Northern Ireland, I believe, already did 2-year screening because they did not have capacity for 1-year screening for everybody. So I think they've been doing it for a little while. Other countries, so it's very, very patchy elsewhere. Anyway, Europe, what am I thinking? US, it's all really, really patchy. So in the US, they wouldn't have screening programs as such. They would rely on ophthalmologists. It's a private healthcare system, so you pay to go and see your ophthalmologist and get your screening done. They do recommend that it's done every 2 years.
Yeah.
By an ophthalmologist. So that is the US. Europe, it depends on where. So little patches of Spain will have screening programs, but it's certainly not national or nationwide. Iceland does have a screening program. I believe Denmark have a screening program. So it's really, really patchy in Europe and the rest of the world.
So the UK is kind of leading its way.
Yes, very much so. The UK is leading the way on this, and then other country. If you look at other continents, so if you look at Africa, for instance, they can't do eye screening, so they're doing it in very different ways. India would have different ways of doing it. They're more opportunistic screening, and they're also utilizing AI as well in grading.
Interesting.
So, yes,
and what's your thoughts on AI? It was our whole hour chat on itself.
That's a whole other hour or two, I think.
We'll book you back next year for that.
Yeah, I think there's a lot of potential for AI. So whether it's within the grading field, and we're still struggling to work out where it should sit within the grading field, or whether it's in using a retinal image to tell us more about other conditions. So there's a lot of research going on now that says there are certain changes in the eye that will predict 5-year risk of cardiovascular disease, stroke, might predict kidney disease, might predict neuropathy. So in the future, we could take retinal photographs and tell you a whole raft of risk prediction out of that image. So it's an exciting field at the minute, and everybody is racing each other to try and get into it. But it'll be exciting in the future, I think.
Yeah. A couple of comments come through. Natalie says, in France, my endo asked me to do an eye screening every year. That's brilliant to hear. Linda says, has anyone had any discussions about their eyes at hospital appointments, apart from your annual checkups? Linda says that she's not in 51 years living with type 1 diabetes. Hashtag diabetes awareness. Okay, last couple of questions. You mentioned before, so obviously the screening letters, and you talked about resources and signposting people to the correct places. I think tonight's chat's been very informative. We try to cover as much as we can. There's probably so much more we could have covered. So if I was to say to you now, Becky, like, what resources, websites would you recommend people to go look at to find out more information or guidance or whatever, a starting point? Obviously, we want people to speak to the diabetes team. Everyone's care is individual. We hope tonight's chat has raised awareness, and it's not to scare anyone, it's just to raise that awareness. But what resources, websites, or anything that you'd say, this is what I would go look like? What would you signpost to your patients or students? Or
so there are so NHS obviously has its own website that it does have a section on diabetic retinopathy, and then other resources. So I've done quite a bit with Diabetes 101. So there are quite a few resources now that are on the DSM forum website for the Diabetes 101 section. I also did a YouTube video for the Diabetes 101 conference, and I've done, obviously, this year with you guys, you've got a presentation from me as well. So those are all really, really good. Diabetes Research and Wellness Foundation has just revamped their leaflets on diabetes and eye health, so that's a really good resource. And Diabetes UK and those sorts of charities will have a lot of information on it as well, so you can go and get more information from them.
Brilliant, thank you so much. And I'm sure like I said, anyone else, go back to your teams. They will support you. Or if anyone has any questions, you can drop Becky a message, and I'm sure she'll help point you in the right directions. Final questions. From your knowledge and awareness, like, is there like specific support groups or peer support communities that you're aware of that like are in within this sort of field of what we've been discussing tonight? I know when I came to the conference you spoke at a couple of months ago, the lady who was co-presented with you was talking about communities and stuff like that. So I just wanted to see if you wanted to take the opportunity to kind of mention that.
Yes, so shout out to Bernadette Warren. She is amazing. She is a person with type 1 diabetes who also lives with sight loss, and she does so much work supporting people living with diabetes and sight loss, as well as helping healthcare professionals to understand what it is like to live with sight loss. She's amazing. She runs a support group for diabetic maculopathy for the Macular Society. They meet every month on a Wednesday evening on Zoom. So if anybody does want information on that, I can certainly put out a little information sheet for that. So the Macular Society do have support groups. I don't think there's anything specific for proliferative retinopathy as far as I know.
Yeah.
But each of your own diabetes teams may well now have sort of peer support groups, and there will be people within those support groups living with all sorts of different stages of diabetic retinopathy. So, I think the main messages are that if you get retinopathy, it's not your fault. You live with a relentless condition that even if, so DCCT showed, so the Diabetes Control and Complications Study showed that even if your HbA1c was 6.5%, there's still a risk of you developing diabetic retinopathy. So, it's not your fault. It's nothing you've done wrong. It's just the fact that you live with this condition and you're just trying to do the best you can. So I think it's not your fault. You're not alone. Other people live with diabetic retinopathy as well. So there are people out there who can help you and support you.
Amazing.
And one other thing I wanted to say was with hybrid closed loops, with the new treatments now for diabetes, and we do have, believe it or not, new treatments coming through for diabetic retinopathy and diabetic maculopathy as well. I do think that we are going to get to a stage now where, when I said 90% of people living with type 1 diabetes for 20 years would have diabetic retinopathy, I think certainly with hybrid closed loops, I think we're going to start seeing that fall in, and we're going to start seeing less and less people actually developing diabetic retinopathy, and even less people ending up with sight loss. I mean, that people who get sight loss from diabetic retinopathy, those figures have been falling since we've had screening anyway. But I do think now with these new technologies coming through, I really do think that there is some bright futures, and I think we're going to see less people getting complications.
Amazing. You've answered my last questions. I was going to say, what's your top tips and advice, and what's your hopes and aspirations for the future? And you've just done it. So, no, honestly, it's been spectacular tonight. Very, very informative, but presented in a very welcoming way and really helpful. So I hope everyone listening or who has listened on the podcast when it goes out finds it helpful. Please reach out to your diabetes team, reach out to Becky if you have any other questions, and just keep speaking to each other, and remember that you're doing absolutely amazing. So thank you so much, Becky. Let's just see if there's any questions. Claire, was any questions from anyone else listening other than the questions I've mentioned this evening? Anything else?
We've had a question from Gillian, who's on the panel, so I don't know if she wants to ask it or whether she wants me to ask it.
Yeah, I can ask it, Claire, if you want. Becky, I was just curious. I had to have a repair to a slight tear in my retina. Does having something done like that, or having cataract surgery, does that make you more vulnerable to developing diabetic retinopathy?
So having treatment for your retinal tear wouldn't have. Obviously diabetes can cause a retinal tear, but I'm assuming you're saying that you had the retinal tear and it wasn't related to your diabetes.
No, it was a PVD with a retinal tear
right,
along with it. Yeah.
Yeah, so it's that doesn't increase your risk. If you have diabetic retinopathy and you have a cataract removal, that can make the retinopathy get worse in the short term. So there is a risk, and they will follow you up more closely. But the problem with the cataract is that it'll mean that we can't actually see accurately into the back of your eye anyway. So we don't really know the stage of your retinopathy before you have the surgery. So it's a bit difficult, but yes, it can make your retinopathy worse.
Thank you.
Thank you so much, Becky, for joining us tonight. Thank you for the questions, Gillian, and everyone else that has commented. Jimmy says, diabetes eye screening program here in Northern Ireland is great. I have nothing but praise for it. #diabetes chat. But thank you for everyone that's joined tonight. Send the comments through, the questions through. And above all, thank you to Becky for your time and coming along tonight and speaking to us for like pretty much 2 hours, hanging out with us. But it's been really helpful, very informative, and hopefully people can listen back on the podcast as well and get more knowledge and insight. So thank you so much.
We've just had a message from James as well with a question. Wanted to know if we asked about chronic kidney disease for someone with diabetes and retinopathy in terms of risk screening and requirements. I hope that makes sense.
Yeah, so unfortunately retinopathy and nephropathy tend to go hand in hand, and you would usually develop retinopathy before you develop the nephropathy. But if you've got nephropathy and you're then you need to be undergoing eye screening. If you are on dialysis, you will probably need more frequent eye screening. But the problem with that is that you are in the hospital so frequently that it's quite difficult, and screening programs don't generally tend to come out to dialysis units to do the screening. So it's a little bit of a tricky situation, but you do need eye screening if you've got chronic kidney disease.
Thanks, Becky. I hope that answers James's question.
Thank you so much. Again, Becky, thank you for your time tonight. And it's been really great and really appreciate it.
Thank you. Thank you, guys.
Thank you.